Welcome to Solutions Rising. I'm Rachel Branch, and I first want to thank Dave Fabiano, the Executive Director of NBCTC, Nicole Brown, our Director for this program, for our programs, Paul Marino, the Program Director of NBCTC, and Mike Putnam, founder and producer of WMNBLP 107.1, our hometown radio station, and all the community TV stations that carry Solutions Rising. And on this program, I'm joined once again with two very distinguished guests, Dr. Paul Donovan, an emergency and sports injuries physician who is practicing at Northern Berkshire Orthopedics, affiliated with Dartmouth Hitchcock Southern Vermont Medical Center, and MCLA Professor Emeritus of Sociology, Maynard Seider, PhD. Both are to be thanked for the great public service as authors of exceptionally important historical books. Dr. Donovan has written a trilogy, The North Adams Regional Hospital, an historical perspective, which includes part 3 on the closing of our hospital. Professor Dr. Seider has written The Gritty Berkshires, A People's History from the Hoosick Tunnel to Mass-Mocha. This program is the 4th program Solutions Rising is presenting on the closing of our North Adams Regional Hospital on March 28, 2014. To begin with, I'm going to ask each of our distinguished guests for additional thoughts and comments on the closing and what they uncovered in the writing of their respective books. And I'll start with Dr. Donovan, Paul, and then with Professor Seider, Maynard, to comment. So the floor is all yours, Paul.
Thank you very much, Rachel. Thank you for asking me to be here. It's a pleasure. So we had a prior program, and we talked extensively on part 1 and parts 2, which spanned the time period from the initiation of the hospital in 1882 and its opening in 1885 through 1910, which was volume 1 or one of the first trilogies. And in 1910, there was this change in reorganization of the hospital at the administrative level. And then from 1910 to 1955 was the second volume. And 1955 ended with the opening of the brand new hospital of 119 beds. And at that time, that hospital was completely paid for by the time it opened. Fairly significant given the fact that over $2 million were raised at that time in less than 2 years by the surrounding community and businesses. So that was, I thought, very impressive. And then the last volume is from 1955 to the closing in 2014. A few highlights of the early hospital starting in 1955. You know, from 55 through the 70s and into the 80s was really a time of growth and prosperity for the hospital. The hospital opened with 119 beds, a brand new hospital, and it grew over that time period. And in 1970, they actually added the north wing to the hospital, which was an 80-bed addition to the hospital. So in 1970, when the north wing opened, there were 200 beds at the hospital with over 850 employees. So that was really the height of the hospital activity and services provided to the community at that time.
So in 1891, they opened, of course, I love this because it was my great-grandmother, the north wing of the old hospital, and adding beds, and in 1970, they opened a north wing, adding beds again. And I bring that up because we're fighting for beds.
Right, and when you think of the area having a 200-bed hospital, to me, that's pretty amazing. Now, at the time, I think the population was a little greater, but nonetheless, that was, from my standpoint and my research, very impressive. And then into the 80s, at the late 80s, early 90s, there was basically a shift in hospital care, and probably dictated by governmental agencies and also insurance companies in ratcheting down in the number of inpatient beds, so to speak, and emphasizing outpatient services. And so as we enter the 90s, not only did they emphasize ratcheting down on inpatient beds and the emphasis on outpatient services, but the state and federal government also, and the insurance companies, decreased the reimbursement for such services during that time. So the 90s was not a difficult period for the hospital, but it had its ups and downs fiscally through the 90s into the year 2000. Although looking back, the centennial was in 1985, celebration of 100 years of the hospital. A few of the other things that happened during the early years in Volume 3, the Massachusetts Nurses Association was elected as the bargaining unit for the nurses at the hospital in 1976. SEIU was the bargaining for the service workers starting in 1980. So, and Maynard, you may want to comment on that, the unionization of the hospital, because I think that's an important aspect of the hospital. And through the 90s, there were a number of programs that flourished. In 1989 is when the Greylock unit opened. That was the psychiatric and behavioral health unit, which was a 20-bed facility, which was brand new for them. So that was an important piece of the hospital. In 1992, the With Child program was developed for new families, single-parent families, to help them and assist them in the care of those of families like that. The TCC, which is the Transitional Care Unit, opened in 1994, which was a skilled nursing facility, a step-down unit to be used within the hospital, that transition before maybe going to a nursing home for rehabilitation for certain patients. So there was a number of programs started at the hospital during the 80s and 90s that contributed to the care of people at the hospital and within the community, worth mentioning. In 1997, the Balanced Budget Act, the Federal Balanced Budget Act, was passed, which unfortunately significantly reduced Medicare reimbursement for the hospital to the tune of $6.8 million over several years.
So that's where that started.
That's when that started. And coincident with that was the fact that that's where the critical access designation came into play. That Balanced Budget Act started that designation in an effort to assist rural hospitals because the federal government recognized that rural hospitals were struggling with reimbursement and staying open, et cetera. So they allowed rural hospitals to apply for this designation, which would subsequently increase Medicare and Medicaid reimbursement to the hospital to a dollar for a dollar type of thing.
So that's 100%.
That was 100%.
And this we're in the 1980s now?
That was in 1997, that designation came. I don't want to get ahead of myself, but later on when the hospital had financial difficulty and was in the process of talking about closure, they had applied for critical access designation. And I had been through a critical access application before in my previous work when I was practicing in North Carolina, and the hospital didn't meet the criteria for critical access. The critical access criteria was that you needed to be at least 35 miles from another hospital institution, which we weren't. Berkshire Medical Center in southwestern Vermont is actually closer than that. Also that you had to have less than 25 beds in hospital. And at the time of the closing, we had 40 beds. So we didn't meet 2 of the 3 criteria. We did have an emergency department that was open for 24/7, and so that was one of the criteria which we did meet, but we were never going to get critical access designation. Plus, the other thing to realize is at the time that the hospital applied for it in 2013, the federal government was already de-designating some critical access hospitals because they found that they wanted to save money on Medicare. So they actually started decertifying some critical access hospitals. The only critical access hospital around is, of course, Fairview and Great Barrington, which received that designation in 2004. So again, it's worth speaking about the critical access piece of things.
Yes, because that's something that we all wanted. This is a cascade of events.
Right. So then we get into the 2000s, and there are some positives that happened to the hospital in the 2000s. The ambulatory care center, which was the 30 office building that was newly constructed to take the place of the doctor's office building up there. And that was a brand new facility that was accessed right to the hospital. That was a very good addition. In 2005, Cambio Associates was a consultant that came in to try to reorganize the administration and the financial structure of the hospital. So to the hospital's credit, they recognized they were in some financial difficulty, and they employed these consultants who seemingly, at least temporarily, turned things around for a while. Also in 2005, the CARE campaign was started. This was a community-wide campaign to raise money for a modernization of the hospital, and modernization and further expansion of the hospital. And that modernization and expansion opened in 2006 with the addition of renovation of the operating room suites, excuse me, an addition of operating room suites, addition of rooms to the emergency department, ICU, maternity, and also endoscopy suites, and a new lobby. And that opened in 2006 to the tune of the cost of $20 million. However, the CARE campaign subsidized a lot of that because the CARE campaign over 2 years raised $12 million. So the community was quite generous in contributing to that CARE campaign.
And the critical care ICU was already completed.
That's right.
It was when my mother passed away, and she was in that new unit.
And for individuals that were working at the hospital at the time, the hospital was quite impressive then. The ICU was a beautiful facility, really state-of-the-art.
Really?
Everywhere they did, it was state-of-the-art. And then in 2009, the Wound Healing Center opened up with hyperbaric. So there are a number of positives in the 2000, from 2000. But unfortunately, that decade represented progressive yearly fiscal losses. So between 2000 and 2014, the hospital overall debt was increased by $28 million. And prior to the closure, the debt that the hospital owed was $49 million. So if you look at the causes or the main causes of factors contributing to the hospital closure, it was really, number one, that enormous debt, and the fact that the bondholders would not renegotiate that debt, number one. Number two, if you remember the sale of the purchase of Sweetwood and Sweet Brook, the retirement community and the nursing home facility was purchased in 1999 for $19.9 million, and then subsequently sold in 2010 for $6.6 million. So there's a loss of almost $14 million. So you couple that with the existing debt, and that's how you basically reach the $49 million.
Was the public aware of, after the 2000s, in the early 2000s and going on, the increasing debt that the hospital owed? Was it public knowledge?
I don't know that. I mean, each year the hospital would publish their fiscal year gain or losses, but I certainly don't think. Personally, I never thought the hospital would close. I've said this before. I always thought it would downsize, but I never thought closure was a possibility. And I don't think the public realized the extensive debt and the cumulative debt over the years that occurred at the hospital.
And of course, you and I talked before about investing outside of the community and the fact that it was stable financially stable for 129 years. And of course, that's why the North County Cares Coalition came into existence. And we're still, we're not going away.
And one of the other factors is the hospital talked about trying to affiliate with a larger health system, but it never came to fruition. It just never happened. And I think, you know, as a rural hospital, that's one thing that will save a rural hospital is affiliating with a larger institution. It's certainly, Bay State sort of has that model of being the mothership with a number of small area hospitals around it feeding that system. Southwestern Vermont's affiliation with Dartmouth. So I think the affiliation piece, which failed to happen, was very important or would have been very important in part saving the hospital.
In another way of saying
yeah.
it, yes.
So, and then of course, then we're left with all that debt and then the subsequent closure and lack of critical access designation, which all led to the closure basically.
Just amazing.
Yeah.
Just amazing. Thank you, Paul.
Sure.
And Maynard, let me see where you are. We'll have Maynard. It's your turn to say whatever you like and add to what you did with our individual program. Welcome.
Sure. Okay, thank you. Thank you, Rachel, for having me, and good to meet you. Good to meet you virtually, Paul. Hopefully we'll do it in person one of these days. Let me just comment on one of the last things that Paul said. He mentioned Bay State. And from what I understand, Bay State is a very profitable operation, and it controls a hospital in Palmer, which actually loses money. But Bay State has decided to keep it going, that they have enough reserves in order to keep the Palmer Hospital going. So people in that area do have a full service hospital. I mean, I say that just to say that Berkshire Health Systems, Berkshire Medical Center, does have choices as to what to do in North Adams. You mentioned that there were Medicare cuts starting in 1997, and I would just build on that a bit just to remind people that was during the Bill Clinton administration. And what you begin to find, particularly with the Clinton administration and even moving forward, is more and more sort of a conservative bent of the National Democratic Party, more and more concerned about deficits, more and more concerned about costs and social programs. So you may remember Clinton ran on ending welfare as we know it. And in fact, he ended welfare as we know it, which led to increasing poverty among large parts of the population. So I think cutting back on Medicare costs, cutting back on urban programs, cutting back on welfare was kind of the theme and the actuality during that particular period of time. So it's not surprising that the hospitals got caught in that way as well. And just thinking about, you know, if you stop and think about why would you want to close a hospital? And then if you ask alternatively, why would you want to close a military base? There's no complaints about the cost of a military base, but there's the cost of what a hospital actually is. I was, I guess, surprised when the hospital closed, as were many, and I hadn't done much studying on the history of hospital closures. I mean, since then, as Paul has mentioned, there've been a huge number of hospital closings, particularly in rural areas, which means poorer areas, which means people don't have access to cars in many cases, which is part of the problem in North Berkshire. And one statistic that really sticks out to me is that from 1975 to the present time, the population of the United States has increased by 50%. There's been a 50% increase in the population of the United States. If you look at hospital beds, there's been a 38% decline. So at the same time that the population has gone up by 50%, the hospital bed population has declined by 38%. And we saw that problem with the COVID, right? all of a sudden there weren't enough hospital beds around. One disappointment that I had with the closing of the hospital was basically the view of the state government and many reps that, well, we can't do anything about it. It's just a part of the reality, and we'll just sort of move forward from here. And Paul, I wanted to ask you about the critical access care. I know at one time there was the 35-mile limit, then I've heard the 20-mile limit, and I know Fairview is just 20 miles from Pittsfield. North Adams also 20 miles from Pittsfield. The Fairview region is a smaller demographic region than North Berkshire, more births in North Berkshire than in South Berkshire. So I guess I don't understand how one got the designation and the other didn't. It sounds like maybe criteria have changed over time.
Well, I'm not. Yeah, it's possible that criteria changed over time. I also asked that question, and it may have been because the politics at the time, there was someone intervening on Fairview's behalf. Or at least that's what I heard. I can't prove that, but the other thing is that, as I mentioned, the government was actually looking to decertify. In fact, they decertified 20% of the prior hospitals that had that critical access designation in an effort to save money. So over time, what's happened is fewer hospitals are receiving that designation. And so, Fairview received that designation in 2004. Here we are 10 years later applying for that designation. And I think that the criteria has changed for better or worse with regards to that, published or unpublished criteria, so to speak.
And I guess excuse me.
The goal is to save money rather than to give the people in the area the health care that they need. I mean, if it's set up that way, that's the result, I guess.
Correct.
I wanted to ask you about Sweetbrook and what's the other one called? The Suites, they call it.
Sweetwood.
Now, why would the hospital want to do that? Why would they want to have to go into debt in order to buy two facilities that are not directly connected to the hospital?
In the mid-'80s, the hospital became a subsidiary of Northern Berkshire Health Systems. And I don't understand all the business aspect of that, except that it now allowed the health system to purchase things outside the hospital. I can only give you a reasonable explanation for Sweetbrook. Sweetbrook was a nursing home facility, and if you're a hospital who needs to move some of their inpatients to a less skilled facility, then it, at least in part, makes sense that you have a nursing home or rehab center to do that. I can't answer the Sweetwood retirement community because that really didn't, to me, make practical sense of that. But maybe they came together, so to speak. Maybe they could only purchase one with the other. I don't have a good explanation for the Sweetwood portion of that.
Sweetwood was not about health care.
It was a retirement community. Yes. So
very elegant one, frankly.
I'd like to answer that, but I can't, Maynard.
Yeah.
I mean, one of the reasons why I ask that, because I've been reading about, different kinds of hospitals. I mean, there are private for-profit hospitals. There are public hospitals that are run by the city and the state. And then there are the nonprofit hospitals like North Adams Regional and Berkshire Medical Center. And to be a nonprofit hospital, you don't pay local taxes, you don't pay federal taxes, and you're supposed to have an obligation to the community, which is a very kind of vague kind of term. So I guess I'm wondering what the Board of Trustees was thinking when they bought those facilities. As you mentioned, how does that serve the community that they're supposed to serve? And so I just wonder, you may not know the answer to it because it is a very sort of vague, elastic kind of term. How do you determine what is in the community interest?
Yeah, you raise a very good questions that I can't answer. I wasn't on the board at the time. I don't know what the thinking was or the justification for doing that. I can only tell you that there were a number of pieces of the health system. There was, of course, VNA and hospice, Visiting Nurse Association and hospice. There was the REACH arm, which had to do with wellness within the community. And if you remember, in the late 90s and early 2000, wellness was the sort of catch-all term for, preventive health type of thing. But again, you have to remember the real mission of the hospital, which changed obviously over the years, and encompassed other things other than outpatient, inpatient hospital care.
So a little technical matter, we don't know what our time is. So could you let us know how our time is running?
Can I say one other thing to
Sure.
just give you the magnitude of the service provided by the hospital? When the hospital closed, I'll just give you some statistics from 2013. There were 20,000 emergency department visits, 20,000 plus emergency department visits. There were over 300 births. There was 4,000 inpatient days at the hospital that year. There was greater than 1,500 endoscopies and colonoscopies done, greater than 2,000 inpatient surgeries, and greater than 2,000 outpatient surgeries, and over 100,000 tests performed on an outpatient basis at the hospital, just to give you some numbers in terms of the magnitude of what the hospital did and the work that they did.
And Paul, in 1 year, 20,000 emergency room visits?
Yes, and that was, and at one point it was 23,000. Yes.
Wow.
Yeah. Yeah.
So want to have a little conversation on the Stroudwater report and what happened to why we had such difficulty getting beds and the actual closing of the hospital, like each of you to.
Right. So the Stroudwater report, the state commissioned in the summer of 2014, Stroudwater Associates from Maine, to do a healthcare study of Northern Berkshire and to find out what the healthcare needs were. And they basically came up with 4 recommendations. Number 1 is that expand primary care. Number 2, they did recommend inpatient beds, med-surg beds, and psychiatric behavioral health beds, although on a limited number, obviously. They recommended maintaining emergency department open 24/7, which we currently have, and also expanding prenatal care. So that was their overall recommendations. There has been some expansion of primary care, although not to the extent it was before the hospital closing. We do have a local emergency satellite facility, and we do have prenatal care now. But obviously there's no inpatient beds, med-surg or psychiatric. So they
Or
didn't,
addiction, yeah, well, that's
no, they didn't take
psychiatric.
all their recommendations,
Yeah.
obviously. So.
Yeah. And once again, we could not get beds, and that was something North County Cares Coalition, we went to city council, we went every place we could to try to get beds. And
Correct. Yeah.
for me personally, it's just like, geez, it's 1891, here we are again.
Yeah.
And you added beds in 1991, and here we are, still fighting for beds, which we do not have.
Right. Correct.
So the Stroudwater associate's report was, I mean, couldn't have been more clear, clarity of the needs here.
Right.
But the opposition, and maybe Maynard, you could speak to the elected officials' opposition to, and any discussions you'd like to have on union commitment to our hospital would be appreciated.
Well, I'll say a few things about that. I mean, one, just sort of thinking about the Stroudwater report. I remember, people were really angry and upset when the hospital closed, and they had various kinds of demands. And they said, "Okay, we'll see what you people in North Berkshire really need, and we'll bring in a third party, a neutral party, a party that's done this kind of research before." And they bring in the Stroudwater people. And the Stroudwater people say, "Yes, you do need a full service hospital, and but we don't have one." So something seems to be missing in terms of the role of the state, the role of the government, and the actual specific needs of the population, which isn't coming from the unions, which isn't coming from the population, but which is coming from a third party that the state hired to do the analysis. I think one of the things that I learned from Paul's book in the timeline is that as things were getting harder and harder for the hospital in terms of finances, both unions actually made some changes in their contract to save the hospital some money, probably at the same time that the hospital was hiring a union-busting law firm from Ohio to try to keep the suites from being organized. So you get that kind of conflict, that kind of conflict going on. And I want to thank Rachel for doing the public documents call from the state. And I've looked through some of the public documents that she's received, based on what was going on between the state and the hospital once things were getting really dire.
And I'll just add that for our audience that doesn't know, there's a record access. I have to find out which camera there got that. There's a record access. It's like freedom of information in the Commonwealth of Massachusetts. And so I went to the Attorney General's office and asked them to provide as many documents as we could get on what happened to our hospital in contacts with the Attorney General's office, which was very disappointing to me. For us on the North County Cares Coalition is that we were waiting for a final report and nobody was held accountable. And as far as I know, no final report was ever produced. So Maynard, I'll go back to you.
Just say a couple of things about it from the documents that Rachel was able to get. One of the things that we found out is that at the end of January, the chair of the board of North Adams Regional Hospital was contacting the Attorney General's office about the dire condition of the hospital and that they may have 2 months to go before they would have to close. So in other words, the state knew as early as late January about the fiscal condition of the hospital and its possible closing. They may have known before that, but from the documents that we got, they knew from at least the end of January. Rachel asked for any documents that connected government officials with the hospital and with the state in terms of the situation at the hospital. And the only documents that came through came from Senator Ben Downing, who was the state senator at the time. And let me just read a little bit of what he had to say, because he really was very thoughtful about it. And this was a proposal that he had that he thought might keep the hospital going. He talks about the short term, the medium term, and the long term. So short term, the hospital could use $2.5 to $3 million. Medium term, and this is really interesting in terms of how decisions are made at the hospital. Medium term, he suggested a new figuration for the Board of Trustees. I mean, historically, and this is the case in Pittsfield, the Board of Trustees of hospitals are often people who are up in the banking community, the business community, very often doctors associated with the hospital itself. What Ben Downing suggested is that 2 members of the board should be from the unions, one from 1199 and one from the MNA, and a third should be an at-large community member, which would really lead to different kinds of discussions at the board of trustee kind of level. He also said that the board should develop a turnaround plan that achieves a break-even status for the hospital, and it should involve a lot of community participation in terms of the hospital needs. Long-term, he talked about trying to increase the rates that the hospital gets, and with the recognition that the hospital might have to become smaller. So those were his suggestions. I didn't see anything in the documents that Rachel received that any of the government officials, responded to them, thought about them, tried to make any of them work. What makes it even more difficult for me to see that lack of concern is at the same time that the hospital was closing, the legislature granted MassMoCA $25.4 million to rehab another building. Nothing against the museum at all. This wasn't going to save the museum. It was going to enrich the museum by one more building. And it just seemed to me that that was indicative of the way in which the state was going, is to support institutions like the museum, which might bring in more tax dollars to North Adams, and we're not going to save this particular hospital. So a lot of, I think Ben Downing's ideas, particularly in terms of the structure of the board, are very, very good ones. And trying to make the hospital more of a community hospital than kind of a corporate hospital, which is the way it seemed to be going, and is the way that its parent in Pittsfield now seems to be. And getting back to the suites, Berkshire Health Systems, besides having the hospital and the VNA and all of that, owns 20 rehab nursing homes, 8 in Berkshire County and 12 in other parts of the state. So they also are an empire that seems to be growing and growing and growing. And one wonders, does that take away from running of the hospital itself in the same way that what happened with NARH?
And I guess one of the things I have said on one of the programs, I think with Dr. Donovan, was systemic structural changes that need to be made for how our healthcare is provided. And there is no reason this couldn't have gone back to be a community hospital, even a cooperative where people had memberships or part ownerships in it. And I didn't know until I got involved with this how many arms there are, financial arms, to healthcare systems that just, this isn't about making money. This isn't about the bottom line. This is about taking care of people, and that seems to be primarily the most important aspect of having a hospital. Now, I handed you a document. There was another report or member that I handed you in the beginning who had sent that letter I gave you. I think it's underneath your other one. It won't be on that. It's that I gave you at the beginning of the program.
Right. Yep.
About another proposal that was sent, I think, to Deval
Patrick.
Governor Patrick at the time, and the name of there are 2 names on that.
Alan Seider, PhD.
Alan Seider
and Deborah Sokola,
yes.
MPH. Yes.
And this was another proposal sent to try to save the hospital, and from what I understand, it was also getting to so many millions of emergency funds that could have been accessed to also save the hospital.
Correct. Yeah.
And that was, very important. It just seems like we were let down by practically every elected official, and people were not held accountable. This seems to be pervasive today, that people are not held accountable, not just in the hospital, but in our governing
right.
systems.
And it's worth mentioning, because I wouldn't have thought about this at all, but Stephen Shepard, professor of economics
yes,
at Williams
yes.
College, summarized the economic consequences of the closing of the hospital on the Northern Berkshire community. And I think there's two very startling things to me. He said that his conclusions were that the economic output in the region would decline by $93.3 million as a result of the closure, half of which was labor income, not directly associated with labor at the hospital, but indirectly. So $93 million is just phenomenal to me, that's what the impact of that closing has. That's, that's a significant amount, I think. And the other thing that he mentioned too is he said total losses to local and state revenues would be upwards of $4 million and $8 million in federal revenues. So here it is that the state and federal and local will lose revenue as a result of the closing. So if they had tried to buoy up the system by funding some of that, they would recap it on the other end, right? By continued revenues. But that figure, both of those figures are remarkable to me.
And I'd really like to know what those figures are, how close they are right now, today.
Yeah.
And I also go back to what Maynard said about the $25 million that went for rehabbing another building at Mass MoCA, but I think they got 30 to 35 million when they opened that. So there's almost $60 million going into a museum. And once again, we can't even save our hospital.
Right.
And to have the community find out within 3 days that it was going to close, nobody had any opportunity to prepare. Not the nurses, not the doctors, not the community, not the patients,
Right.
not the businesses, the local businesses. And Stephen Shepard's economic report is extremely valid. If we had had this information ahead of time, I'm not so sure this community, being the community that it is, would not have just broken their backs to find a way to save this hospital.
Right.
So this was blindsiding at its best and with the worst possible effect.
Yeah, the 3-day notice for closure is almost unthinkable, really. I mean,
Yes.
and maybe that was done because of the outcry that might have occurred if it was a 60 or 90-day notice type of thing.
But the outcry might have provided some solutions for
right. Sure.
saving the hospital.
Absolutely.
And might have allowed also elected officials who did not do anything to put pressure on the elected officials to say, yes, you must find this money, find it federally or through the Commonwealth.
Correct.
That emphasis, that's how you get things done, is you
Right.
have to have people allowed to participate and have the information to know how to participate.
Sure.
So that's part of it. So
On the other side, it set a pretty low bar. I know that they closed a hospital in Quincy later that year or the following year, and people in Quincy were complaining, and the Quincy people were told, look, we gave you 2 months notice, not like those people in North Adams got only 3 days.
ooh,
So that became a new bar. As long as you give people more than 3 days notice, you're being a good public citizen.
ooh, I didn't,
I mean, I think we're not going to get this solved until we get, a rational, people-friendly, people-concerned healthcare system. Whether you call it single payer, Medicare for all, one that can keep drug prices down and could have other concerns rather than saving, money in a rural area, we're going to continue to have these kinds of problems. So, I mean, hopefully we'll move in that kind of direction. I mean, I think it's going to take really national policies to make the changes that we need. I mean, we've all seen the data on the per capita expenditures for healthcare in the U.S., which is number one of all the countries of the world, but we rank maybe 135 in terms of our access, mortality rates, morbidity rates, and things of that nature. So it's not working for most of us. It might be working for the pharmaceutical companies and for the private hospitals and so on, but for the average citizen, it's just not working.
this is just bottom line mentality. It's fiscal responsibility, and the bottom line ought to be working hand in hand with healthcare primary, making it work primarily. And actually, I would like to add in this conversation a discussion of the effects of the COVID-19 pandemic, and how that has affected people in northern Berkshire and other rural hospitals. Certainly, who would ever have expected, even though there's been forewarning for quite a number of years about pandemics, and there'll probably be more. But I would like to know your thoughts on COVID-19 pandemic, and whoever would like to start. Do you want to have a comment, Paul?
Well, my comment is it's been a difficult year on the medical side of things, dealing with COVID. Historically, I think it's worth mentioning, there was a smallpox epidemic in 1904 where the hospital was quarantined for 5 weeks, and they opened up a facility downtown where they took care of individuals with smallpox. That's just historically, I think, worth mentioning. And of course, we know the pandemic of 1918, the influenza pandemic, which took 600,000 US lives. We're very close to that on the COVID side right now. We've reached 550,000 lives taken with the COVID epidemic. I think as a health system, locally we've done pretty well. I don't think nationally, certainly we prepared for it, and the not looking to the government to, have that response, but their response was, I think, slow, delayed, and inadequate, and it was really up to the local medical facilities to deal with that, and I think they've done their share of the work, but certainly from a state and federal standpoint, more could have been done.
Absolutely, and I think of the loss at Williamstown Commons of 24, and I knew a few of those women that were lost. I mean, just unacceptable, the lack of preparation for that.
Yeah.
And, but Maynard, would you like to comment on that aspect?
Well, I'll use the military analogy again. We have more, fighter planes and ships and bombs just in storage, waiting to be used. And we don't seem to be able to have enough personal care equipment, ventilators, and hospital beds waiting around to be used in case of an emergency. For some reason, there's a different view towards how we deal with healthcare and how we deal with the military. And so it wasn't a surprise that we were unprepared for the pandemic. On the plus side, I would say one of the things that the pandemic really showed and brought out are all the inequities within the system. Yes. Whether it's, Black and brown people and poor people having less access to testing, less access to vaccinations, more apt to be, having to work out in the community, and more apt to get COVID. And so, that kind of shining light on the inequities may be a spur to get people more involved in trying to change some of those inequities. I know in Berkshire County, I think one of the consequences of the pandemic and the closing and opening of museums has led to the unionization, of workers at MOCA, and the outpouring of concerns of people working at other cultural institutions in Berkshire County in terms of not being treated fairly. So it leads to that kind of maybe the beginning of a social movement. Sometimes, like out of the 30s and other critical periods of time in American history, there arise social movements that will try to bring about that kind of change. Here in Berkshire County, I think I've seen some of that take place because we, whether it's unionization, whether it's a concern to have more accountability, things of that nature, the inequities that the pandemic showed us brings that out into the full light.
Yes, and interestingly enough, the beginning of our hospital started with the catastrophe of the train wreck. And then every time the hospital was in trouble, the community came forward. So there is this goodness, and I don't think it's just in the United States, worldwide, that when bad things happen, people of goodwill will come forward and find ways to answer it, which just also glaringly points out what did not happen with the closing of our hospital.
Right.
So we are now we were deciding like halfway in the show whether we were going to do 29 minutes or let it go an hour, and we have let it go an hour because both of you have given so much information, additional information, and your perspectives of the two of you being here is just, I'm so appreciative of that. And our 7th anniversary is on March 28th, this Sunday, and I didn't know it would turn out to be this, but I am so glad to have been able to do 4 programs on Solutions Rising, and also connecting with the April 4th Coalition, North County Cares Coalition, and we will be again speaking about this on the Monday night program, and we are not going to let this go away. And maybe if some of the work that we've done all these years and all of us participating will help spur some of the changes and positive healthcare needs that need to be addressed. So as we come down to the closing of now what has turned into a delightfully 1-hour program, I'd like each of you to give me your last thoughts, if you will, and we'll start with you, Paul, Dr. Donovan.
A couple of things. I think that as a rural hospital community, rural hospitals should concentrate affiliating with larger institutions, number one, and really involving the community in participation in the hospital, volunteers type of thing, so that the community can see actually the good work that's done at these institutions, so that you can get strong local support. I think that's going to be the savior for most rural hospitals. They do estimate in the next 2 or 3 years, more than 25% of the current rural hospitals will probably close, and which is just unthinkable, really. And my last thought is, I want to thank you for this program. I think it was an important topic to discuss with the community, and I think it's worth thanking North County Cares Coalition for their persistence in for their support of a full-service hospital.
And it must be said that all those years of the hospital, there were volunteers. And if we do have to affiliate to have beds in our hospital, the community has to have some ownership in that.
Correct.
Definitely, I think, has to have the ownership.
Correct.
Maynard?
I would just say, just thinking historically, about North Berkshire going back, into the 19th century all the way to the present. It's been an area, as far as I could tell from my time there and just reading about it, where people have always volunteered, where people have always gone the extra mile. And I don't know if that has something to do with being isolated with the mountains around us, that you just feel we've got to do it. No one else is going to do it for us. And my sense is, how people felt about the hospital when I was there, they felt so proud about it. Paul, you may remember the date, but there was a period of time where the hospital was thinking of changing its name, I think, to North Berkshire.
Correct.
And the people in North Adams were very upset about it. Don't take North Adams out of the title. And in fact, they didn't take it out of the title. It remained. There was also upsetness about the college changing its name and taking North title as well. So I've always been impressed by the can-do spirit of the people in the area. I got to know them through the unions, through internships, through people at the college, through people in the community. And I mean, I hope and I think with, you know, with groups like North County Cares Coalition and others, they'll continue to come together to push for what we need and make connections on the state and national level in order to change all of those policies.
So I have to, I just am full of gratitude to both of you, Dr. Paul Donovan and Professor Dr. Maynard Seider. I am so grateful that you agreed to come back as guests together. And this has just been quite an experience to have you share perspectives back and forth together, and added so much to the dialogue and the context and the fullness of things that I think our viewing audience and our listening audience too would not have known, including myself. There are quite a lot of things that I've learned just being part of North County Cares Coalition, and we will continue. We will absolutely continue. So,
well, thanks for inviting me, and thanks for letting me meet Paul.
Oh, yes.
Nice meeting you, Maynard. Good
Thanks
talking to you.
Thanks to both of you. And we'll just, to be continued. I'll probably find another way to bring both of you together again on Solutions Rising. And if each one of us pick up one problem and solve it, imagine the incredible view we would all have of Solutions Rising. And I think we have really talked about quite a lot of the solutions, and we will continue to try to find solutions. And thank you once again, Dr. Paul Donovan.
Thank you, Rachel.
Professor Maynard Seider. I am so grateful.